Okay. Thank you, Diane, for that introduction. And then I'm just going to press this button and see what happens. Okay, yeah, that's how you click forward. Cool. So like Diane said, my name is Carly. I am a genetic counselor at Lurie Children's Hospital. And I guess we'll kind of get started. So for agenda today, I'm going to be running through some basics of genetics and inheritance patterns. Might be familiar to some people, kind of might be new to others, but a refresher is always nice. We'll go through different types of genetic testing and then dive into family planning options from there. Okay, so starting with the basics of genetics. So our genetic information, which is what gives our body instructions on how to function and develop, is our DNA. Our DNA is inside of just about every cell in our body, and it's made up of a 4-letter genetic code, or in this photo, a 4-color genetic code. The cell reads this code like words in a book. And a section of DNA that provides specific instructions, like how to make a protein or an enzyme, is called a gene. We have over 20,000 genes in each cell. And as we follow the path of that strand of DNA, you can see that our DNA is packaged into structures called chromosomes. And chromosomes live inside the part of the cell called the nucleus. So, if metaphors are more your speed, then this slide is for you. If you think of our genetic information as a book, then DNA is like the words on the page. It's the instructions read by the cell. Genes are a way of dividing the endless stream of letters into discrete instructions. So you can kind of think of them as chapters in a book. And if DNA is the words on the page and genes are the chapters, then that makes chromosomes our books. They hold together our genes in a neat package. Taking this metaphor a step further, we have about 23 unique chromosomes that all contain different genes. You can think of our chromosomes like books on a bookshelf. And to make things more complex, our cells are avid book collectors, and they tend to have an extra copy of each chromosome pair, just in case. So, in total, we have 2 copies of each chromosome or book, which makes a total of 46. Now, before I lose you to the convoluted metaphor, I'll show you this picture of what chromosomes actually look like when we line them up. And if you use your imagination, you can kind of see the resemblance to books on a bookshelf. Or maybe that's just me. Like I mentioned before, our 46 chromosomes are organized into 23 pairs. We call chromosomes 1 through 22 autosomes, and the 23rd pair are the X and Y chromosomes. Typically, individuals with 2 X chromosomes develop typical female anatomy, and individuals with 1 X and 1 Y chromosome develop typical male anatomy. So, focusing back to the genetic code and our genes specifically, genes provide instructions for the assembly of enzymes. So I listed a couple of examples of specific genes on this slide, which some of them may look familiar. ARSA, or ARSA, is a gene that encodes instructions for making aryl sulfatase A. ABCD1 is a gene that includes instructions for making the adrenoleukodystrophy protein, or ALDP. And the GALC gene provides the instructions for making galactocerebrosidase. And these are just a few examples of the many, many enzymes we have. So what do enzymes do? Enzymes are kind of like the worker bees of the body. They build complex structures or they break them down. So as you can see in this image, the enzyme here is taking one blue circle, one purplish pink circle, and combining them into 2 connected yellow circles. And what the function of the 2 yellow circles is, I'm not sure, but it kind of demonstrates the point. And the specific spelling of the gene, in other words, its genetic code, is important and determines whether or not this enzyme functions correctly. So a genetic variant is a spelling change or a typo. Essentially, it's a difference in the genetic code that may or may not impact the function of the gene and therefore the enzyme. There are different types of genetic variants, and we typically group them into 3 categories. The first is the most obvious. A pathogenic variant is a spelling change that disrupts the function of a gene. Sometimes these types of changes are referred to as mutations. The second type of change is called a benign variant. We all have many genetic variants. We're all unique individuals, and our DNA reflects that. Most of these variants, however, are actually benign, meaning they don't impact the actual function of the gene. And the last category here is called a variant of uncertain significance, or VUS, or perhaps VUS is something you've heard before. This is a genetic variant that we don't have enough evidence to confidently say whether it disrupts gene function or not. It's kind of like a question mark result. And over time, the goal is to recategorize those question mark results into either the positive or negative results. So in the picture on the slide, you can see that the second rectangle is green in the normal copy, or the copy on the left, and red in the variant copy. So this small change may not cause any issues, or it could be just enough to cause signs or symptoms of a genetic condition. So, transitioning into inheritance patterns. Inheritance patterns are just descriptions of how genetic conditions and genetic variants are passed down through generations. So, a child inherits 1 copy of a chromosome from each parent. In this image, the child inherited 1 chromosome from parent A and 1 chromosome from parent B. And this image only illustrates 1 pair of chromosomes as an example, but this process occurs for each of our 23 chromosomes. So, how are different genetic conditions inherited? The main types of inheritance patterns are autosomal dominant, autosomal recessive, and X-linked. So starting with autosomal dominant, autosomal dominant genetic conditions occur when there is a pathogenic variant in 1 copy of a gene pair. So an affected parent, which here in this image is shown in blue, has a 50% chance with each pregnancy to pass on the pathogenic variant to a child. So just to be clear, the bottom of this image or diagram doesn't mean that someone who has a dominant genetic condition will have 2 children without the condition and 2 children with the condition. It's just showing each possible combination of chromosomes between the 2 parents shown. And an example of an autosomal dominant leukodystrophy would be LMN1B related leukodystrophy. Moving on to autosomal recessive. So an autosomal recessive condition is caused by the presence of a pathogenic variant in both copies of a gene pair. For these conditions, having 1 copy of a pathogenic variant is not enough to have signs or symptoms of that condition. But those individuals are referred to as carriers. They have 1 backup copy and 1 copy of a genetic variant. So again, they don't have the genetic condition, but if 2 carriers were to meet, they have a 1 in 4 chance of both passing on their pathogenic variant and therefore having a child with that genetic condition. So with each pregnancy, there's a 50% chance the child will be a carrier, again, not affected, but carrying that pathogenic variant through their generation. And that leaves a 25% chance that the child does not inherit either pathogenic variant. So overall, there is a 75% chance that a pregnancy conceived by a carrier couple will not be affected with the corresponding genetic condition. And an example of an autosomal recessive genetic condition is metachromatic leukodystrophy. So moving on to an example, if someone has an autosomal recessive genetic condition, what are the chances that they have a child with that same condition? Well, that depends on the carrier status of their partner. So if their partner is a carrier, then the couple has a 50% chance with each pregnancy to have a child with the condition. But if their partner is not a carrier, then the couple has a very low risk to have an affected child. because there's no one to pass on that second pathogenic variant. Last but not least, we have X-linked inheritance. X-linked conditions are caused by pathogenic variants that are located on the X chromosome. And X-linked conditions are subdivided depending on whether both sexes, male and female, are at risk for symptoms of that condition. Inheritance of the X and Y chromosomes are a bit tricky. So here, parent A, presumably the father, has one X and one Y chromosome. Parent B, presumably the mother, has two X chromosomes. So their child could inherit one chromosome from each parent. Or their child could inherit one X chromosome from mom, since this is all she can pass on, and one Y chromosome from dad. Now, because females do have a backup copy of the X chromosome, sometimes females are more mildly impacted by the genetic condition than males are. In fact, we used to think that some X-linked conditions wouldn't impact females at all because of that backup copy. However, as we diagnose more individuals with these conditions and listen to those female carriers, we have learned that females can be just as affected as males, or they can be very minimally affected, almost unnoticeably. So you'll notice that I've put dominant in parentheses, and that's because we've started to steer away from using the terms dominant and recessive when referring to X-linked conditions, because we know that females can be symptomatic, even in conditions we once thought to be quote-unquote recessive. So the general concept still remains, though, and that term is still around, so it's important to review. X-linked dominant inheritance is caused by a pathogenic variant on the X chromosome, and having one copy of that variant is enough to cause signs and symptoms of that condition. In other words, females can present with symptoms. So in this scenario, an affected mother has a 50% chance to have a child who is affected regardless of the sex of that child. Now, if the father was affected, all of his female children inherit his X chromosome, so therefore they would all be affected with that genetic condition. His sons, on the other hand, will inherit his Y chromosome, so none of his sons will be affected. An example of an X-linked dominant condition is X-linked adrenoleukodystrophy. And then moving on to X-linked in parentheses recessive. The only difference here is that females generally are not affected. And if they do show signs or symptoms, they tend to be more mild and possibly later onset. So females are typically considered carriers. They have a 25% chance with each pregnancy to have an affected male child. And if the father in this scenario were affected, then all of his female children would be carriers, and none of his sons would be affected, since dad cannot pass on his X chromosome to his sons. An example of an X-linked recessive condition is PMD. So we've spent this whole time assuming that all genetic variants are inherited, but genetic variants have to start somewhere. So genetic variants that are not inherited are called de novo. These variants are new in a child and not passed down from a parent. So in this scenario, the chance for parents to have another child with a genetic condition caused by that de novo variant is less than 1%. The risk isn't zero because it's possible that the genetic variant just wasn't present in parents' blood sample, and that's what we tested, and so that's why they test negative. But we can't rule out the possibility that the variant is present in parents' egg or sperm cells, since we didn't test that type of cell. This is called gonadal mosaicism, and it's fairly rare, which is why the risk is still less than 1%. An example of a condition that's typically caused by a de novo pathogenic variant is Alexander disease. Okay, so moving on to our next topic, we'll review the different types of genetic testing. So first, we have the type of genetic testing that most people are familiar with, called diagnostic testing. Diagnostic testing is done to confirm or exclude a suspected genetic disorder in a person with symptoms. Some pros of doing diagnostic testing are listed here, such as results may lead to changes in medical management. Results can provide information to families about the chance to have more children with the same condition. We call this recurrence risk. And having a diagnosis can open the door to family planning options. More on that later. And a diagnosis can connect people to other individuals with the same condition and establish a community. Or connect people to research studies. Cons include the cost, the potential for an uncertain result, and the anxiety and confusion that can cause, and the very real fear that someone may be discriminated against based on the result of their genetic testing. Now, there are laws in place to prevent certain types of discrimination, but these laws do not prevent all types. However, more often than not, at least in my experience, families weigh the pros and cons of diagnostic testing and generally choose to move forward with testing. Carrier testing, on the other hand, or carrier screening, is a genetic test for people who do not have signs or symptoms of a genetic condition, but it's done in order to determine whether they have one genetic variant for a recessive condition, in other words, if they're carriers. Genetic testing in this specific setting really changes the pros and cons list, so we can take a look. So, could carrier testing lead to a change in medical management for that individual? Well, no, because carriers generally don't have signs or symptoms of that genetic condition. So we can cross that one off the list. The next bullet is still true. Carrier testing can provide families with information on the chance to have children with a genetic condition, so that can stay. Carrier screening can also potentially lead to family planning options if we know what the specific familial variants are, so that pro can stay as well. But carrier screening results don't really connect people with the same genetic condition since it's not meant to diagnose a genetic condition. So that's off the list. And since we aren't diagnosing someone with a genetic condition, we really wouldn't connect them to research studies, so that's off the list as well. So now if we look at our pros and cons list and weigh them, the result is not as obvious. And people in this room may have different opinions on whether the pros actually outweigh the cons in this scenario. That leads me to my next point. Carrier screening is generally not recommended for children, as the pros of carrier screening are mostly relevant for decisions they'll make as adults, and not for their current health or medical care. Essentially, not everyone wants to know if they're a carrier of a genetic condition. So we want kids to have the opportunity to decide whether that is information that they want to know about themselves. So now, we'll move on to a real-world example, but before I do so, I want to acknowledge that so far we have used a very traditional family structure as an example, and families do come in all shapes and sizes. But for the sake of simplicity, for better or for worse, I'll continue to use that traditional family structure to move through 2 real-world examples. So, in this family of 4, we have Justin, who is a 2-year-old male who recently has started to fall a bit more often. Out of abundance of caution, the family was recommended to do a brain MRI, and that revealed early signs of something called demyelination. So, genetic testing was recommended. This would be an example of diagnostic testing. Results come back and reveal 1 pathogenic variant and 1 variant of uncertain significance in the GALC gene. So this gene is associated with Krabbe disease, which is an autosomal recessive condition. And now it would be easy to assume that 1 genetic variant is on 1 copy of the GALC gene and the other variant is on the other copy, but that's not the only possibility. Both genetic variants, in theory, could be on 1 copy of the gene. That would mean Justin is only a carrier of Krabbe disease. Now, since we know Justin's history and the diagnosis of Krabbe disease kind of makes sense, we can be fairly confident that he's probably not just a carrier, but we still need to confirm. We do this by testing both parents. If both copies come from 1 parent, then we know that those variants are traveling together on the same copy of the GALC gene. But if 1 variant is found in dad and the other is in mom, then we know they're on different copies, which would confirm a diagnosis of Krabbe for Justin. So results come back and prove our theory right. Both of Justin's parents are carriers of the variant in GALC. The pathogenic variant came from dad and the VUS came from mom. So now that we've confirmed both copies of Justin's GALC gene have a genetic variant and Justin's medical history fits the diagnosis of Krabbe disease, we can use this evidence to support the change to this classification of the uncertain result and upgrade it to pathogenic, which would then confirm a diagnosis of Krabbe disease for Justin. So, we know both parents are carriers of Krabbe disease. What does that mean for Justin's sister? In theory, she would have a 1 in 4 chance of having Krabbe disease. So, should we do genetic testing? That leads me to the next type of genetic testing, referred to as pre-symptomatic genetic testing. This is a genetic test done in a person with a family history of a genetic condition, but who does not have symptoms of that condition. Before we consider testing an unaffected sibling, we should ask ourselves, could siblings be pre-symptomatic and genetic testing would provide a diagnosis, or would testing just reveal the carrier status of a child? So, back to the family example. Justin presented with symptoms at around 2 years old. People with the same genetic condition do present differently, and even members of the same family can have unique symptoms. But generally speaking, we would expect symptoms to present around 2 years old if a sibling also had the same genetic variant as Justin, especially because this is an autosomal recessive condition and we're not dealing with X-linked inheritance. So, if Justin's sister, let's call her Julie, is 6 months old, she could certainly be pre-symptomatic, and genetic testing would provide meaningful information to the family by confirming or excluding a diagnosis of Krabbe disease. But if Julie is 12 years old, she really is past the age where we would expect symptoms to manifest, so she most likely is just a carrier of Krabbe disease. So in this scenario, we typically would recommend deferring carrier testing until Julie is at least 18 years old so she can make her own decisions about testing. But of course, decisions to do genetic testing are always a personal decision, and you have to do what you feel comfortable and is best for your family specifically. So, for the last bit of time we have, I'd like to review family planning options, which include genetic testing before, during, or after pregnancy. So, before pregnancy, there's the option of carrier screening, which we've already talked about. But something we haven't discussed is a very important detail regarding variants of uncertain significance. These types of results typically are not included on a carrier screening result. So, if we go back to our family from example 1, and go back in time to when Justin and Julie were just a thought in their parents' minds, we can see how carrier screening would play out for this family. So the couple decides to do carrier screening and they opt to do a panel. This is a genetic test that looks at multiple genes at once, but for the purpose of this example, we're only going to look at their results for the GALC gene. Results come back, and it turns out only dad is a carrier of GALC, and mom did not have any variants included on the test report. So, great, the couple's not at risk to have a child with Krabbe disease. Except we know that's not true. Mom is a carrier of a VUS, and this type of result is not included on carrier screening reports. And this brings me to another important point. Negative or normal carrier screening is risk reducing, not risk eliminating. So it's important to discuss your results with a genetic counselor who can provide more information on the risk to have a child with a genetic condition following carrier screening. Our next example is for a different couple, and this time we'll focus on genes located on the X chromosome. And as a reminder, carrier screening is not designed to diagnose someone with a genetic condition, so typically we don't screen males for X-linked conditions since they can't be carriers. They either have it or do not. So we only test mom for the X-linked condition. And we discover that she's a carrier of PMD. As a reminder, this is an X-linked recessive genetic condition, so she doesn't have signs or symptoms of this condition, and she may not be at risk to develop signs or symptoms herself, but she does have a 1 in 2 chance with each pregnancy to pass on this pathogenic variant regardless of the sex of the child. So again, if she passes this pathogenic variant to a female pregnancy, that child would be a carrier. However, if she passes this variant to a male pregnancy, that child would have PMD. Now, not everyone is offered carrier screening before becoming pregnant, and not everyone that's offered carrier screening chooses to do the testing, and that's perfectly fine. It's personal choice. But now that this family knows about the specific genetic variant, this creates additional options for them when deciding how to grow their family. And that brings me to the next type of genetic testing that can be done before pregnancy. This is called pre-implantation genetic testing, or PGT for short. This is a complicated process that involves testing one cell removed from early embryos conceived by a process called in vitro fertilization, or IVF, and then transferring only those embryos that test negative for the specific genetic condition. Importantly, in order to do this type of genetic testing, we have to know the specific variant or variants that are in the family. So I threw 2 new vocab words at you, so let's take a step back and review them in more detail. In vitro fertilization is a process where egg meets sperm in a laboratory. The fertilized egg cells are allowed to grow and multiply until they reach the embryo stage. Then 1 or 2 cells are taken from each embryo through a process called cellular biopsy, and those cells are tested for the presence of the known familial pathogenic variant. The embryos that test negative for the familial variant or variants are then the embryos that are chosen to be transferred to the individual designated to carry that pregnancy. This process is long and it's not always successful. So if you're considering pursuing this type of genetic testing and family planning option, I always encourage families to have a one-on-one conversation with their reproductive team, which may include a genetic counselor, to discuss the risks and benefits of this method. Next, we have genetic testing during pregnancy through one of 2 procedures called an amniocentesis or chorionic villus sampling, or CVS. So both procedures involve using an ultrasound probe to guide a needle to collect a sample. I'm not going to go into detail regarding the differences between the procedures, but broadly speaking, CVS involves taking a sample of the placenta, while an amnio takes a sample of amniotic fluid. And as you can tell by the image, amniotic fluid is just the fluid that surrounds the fetus. The samples are then sent for genetic testing to determine whether the pregnancy is positive for the familial genetic variants. Now, both amniocentesis and CVS involve a degree of risk for complications, which can include pregnancy loss. And the specific degree of risk depends on the institution doing the procedure. But generally speaking, institutions that are experienced with this type of procedure tend to quote a risk of about 1 in 1,000. Again, if you're considering pursuing this type of genetic testing and family planning option, I would always encourage you to have a one-on-one conversation with a genetic counselor to discuss the risks and benefits of this method. Lastly, we have a type of genetic testing done after birth that's not diagnostic, carrier, or pre-symptomatic testing. So newborn screening. This is a test done within a day or 2 of birth to identify infants at an increased risk for a specific genetic disorder, so treatment can begin as soon as possible. Conditions that are screened for on newborn screening depend on the specific state. So in Illinois, we screen for Krabbe disease and X-linked adrenal leukodystrophy, with plans in the works to add metachromatic leukodystrophy in hopefully the near future. So when a newborn screening result is positive, further diagnostic testing is usually required to actually confirm or specify the results, and counseling is generally offered to educate parents and families. And of course, other family planning options that don't really involve genetic testing could include adoption or egg and sperm donation, although egg and sperm donation could include genetic testing. So some key takeaways. I know we've talked about a lot of different concepts, but the things that I would like you to take away with you would be Genetics and genetic testing are complex. I think that's pretty obvious. Variants of uncertain significance are typically not included on carrier screening panel results. Carrier screening is typically not recommended for unaffected children, and depending on the specific X-linked genetic condition, female carriers may actually be affected. And lastly, knowing the specific genetic variant that you or a family member carry introduces the possibility of genetic testing before or during pregnancy. And that's it. So thank you so much for your time. I'd be happy to answer any questions or, talk further on anything specific.
Our situation is that our sons have a variant of likely pathogenicity, and the other one is a VUS. Mm-hmm. At what point does that VUS get added to, upgraded to likely, and who makes that decision?
That's a great question. So it's typically lab specific. So each genetic testing laboratory has their own criteria for classifying a genetic variant. And a lot of times when we have a person who presents with symptoms of a genetic condition and have two variants with that genetic condition, and one of them is a VUS, a lot of times that can be enough evidence to upgrade that variant from a VUS to likely pathogenic or pathogenic. Other times, in order to upgrade a VUS, we do something called functional studies. We can do that through animal models, potentially just making that genetic change happen in a mouse model and kind of seeing what happens and if it does end up causing disease. Other things could be functional assays, so going in a laboratory and seeing the result of that variant and how it performs in the lab. But again, it's really lab specific. Thank you. It's a good question.
Thank you. That was really awesome, clear, easy to relatively easy to understand. I have a couple questions, please. Yeah. Can you define genotype?
Genotype. Yes, I can define genotype. Genotype would be the genetic change that someone has. So let's say, for example, Justin, his genotype would be whatever the pathogenic variant would be. Maybe it's changing the protein at the 250th amino acid from valine to threonine. And that would be the specific variant that he has and his genotype. And then maybe his other variant, that uncertain result, is something a little bit different. Maybe the 251st amino acid is changed. And so his specific genotype is really just the changes to the genetic code.
Which may not be pathogenic, correct?
Correct.
Okay.
Absolutely.
Is it safe to say that a pathogenic variant is a synonym for mutation?
Yes. I think the term mutation was once a lot more common. I think more recently, I personally at least don't love the term mutation. I think it just has a negative connotation, but I prefer pathogenic variant. But yeah, essentially they're the same thing.
Okay. How about allele?
Allele. Ooh. So an allele, that would be, so a genotype is the combination of both genetic changes in each copy of a gene. An allele is an example of just one. So one pathogenic variant would be like an allele.
Are alleles always pathogenic?
No.
Okay.
No.
Last question. You listed a variety of family planning options. Mm-hmm. Isn't there a family planning option where you could take the father's sperm and spin it by weight, and then you can actually kind of choose a male or female?
That is a good question. So basically, sex selection with father's sperm and DNA.
Right, so if there's an affected father, and you know that he would have unaffected daughters, or unaffected sons, right? So you can sort out the X sperm and the Y sperm?
Yeah, I think that is a viable option. I think it's also something that could be done through in vitro fertilization, where the embryos are tested and only male embryos are implanted, for example. But if someone wasn't comfortable, having several embryos and only choosing some, I think that would be a very reasonable option.
Okay, so that's a great point, right? That's something that could be done before creating embryos.
Exactly.
Okay, super. Thanks a lot.
Yeah, of course. Thanks for your questions.
Hi.
Oh, hi.
I'm a little bit foggy on the difference between carrier testing and just the genetic testing to see if the person has the gene. And I'll just give you a specific example. Back in the day, we did have our daughter tested to see if she had it, because we were looking to see if she could be a donor, if need be. And they said, no, she doesn't have it. She has heard from some other sources, she's now over 30, and everybody in that generation is talking about freezing their eggs and so on and so forth.
Yeah.
But she has actually heard that maybe if she should be tested again before she tried to get pregnant. I mean, could things ever change, or is it possible she did not have as full a test as we now know, since we now know women can actually have the whole?
Yeah, no, that's an excellent question. So I think I'll kind of address the different parts of it, but first and foremost, generally speaking, our genetic information doesn't change over time. So if she had a genetic test when she was younger to see if she could be a donor, and that genetic test was looking to see if the specific variant that we know is in the family was present or absent, and it came back absent, then we don't really have to repeat that testing. We know our answer. She's not a carrier of that condition. However, there are many genetic conditions, and it sounds like, at least from your saying, the testing she had before was only looking to see if she was a carrier of that specific condition. So if she wanted to, she could do a carrier screening panel. So that's just looking at several different, some panels have 250, some have 300 different genes on them that screen for carrier status. And so maybe that could be kind of what she's thinking. And so in a way, if the gene that she's already been tested for is on that carrier panel, it's kind of repeating that test, but plus 200 some other genes. Does that answer your question?
Yeah. Well, so the ALD genes are not on that generalized test now, right?
It really depends on the lab, but you're exactly right. There are genetic conditions that are not included on carrier screening panels. Right. And in that scenario, if someone has a specific family history of something, that's when you're going to want to meet with the genetic counselor so you can do targeted genetic testing. Okay. That targeted genetic testing is going to look for the specific variant that's in the family. Because if you just do a broad carrier screening panel, the gene that runs in your family or the variant that runs in your family might not be included on that panel.
Okay. And if she comes next year, don't any of you tell her.
We weren't
She'll
talking about her.
kill me.
All right. Okay. Thank you. Appreciate it.